Uh, Hey, but the putting the videos up on YouTube for all three people to watch them, yeah, that's me. That's not Sean.
Good for you, man. Stepping up in the IT world.
Oh man, it's pretty much a weekly occurrence that Bar Daniel has something sly to say about me and technology, but it's also a daily occurrence that they teach me about something with technology. So yeah, it is what it is. I know my place,
As long as you know.
and it's not tech support, so that's fine with me. Oh, all right. I guess I got to get into the mode. Then really, it really doesn't have to be that much. We're just gonna chat. I'm actually interested to hear what you think about it because this is not a case that really makes me look good. So
That's not what it's about.
it's not what it's about. I was gonna do two cases if we had enough time, and I was gonna do one that I like did pretty maybe picked like the same body region and one that I handled okay, and the one that I just flopped on. But I think this one will be good. So, all right, Sean, you can probably start editing now. All right. Welcome to another episode of R2 Podcasts. I am your host, Dr. Alex Coleman, and I'm joined by fellow Dr. Corey Bailey. And today we're going to be chatting about a case study brought to you by one of my patients that I'm seeing at the farm right now. So let's just get into it. I have a 48-year-old female who presented. This was early in December or late December 2022. So at the time, she had been dealing with this knee pain for about 3 weeks, left knee pain, some pretty decent swelling. When I saw her walk in that day, I was like, "Ooh, she's in rough shape." She was limping pretty heavily. When she noted that it first started, it was just kind of random. Didn't remember doing anything specifically to it. She's very active. She plays tennis 4 to 6 times a week, and also lifts like weights in the gym 3 or 4 days a week. So she's very, very active for her age. And the pain itself was sometimes kind of hard for her to pinpoint, but she kind of narrowed it down to 2 spots. It was like posterolaterally, and she described that as like a hinging or a catch whenever she would move her knee into flexion and extension. And then anteromedially, she had this kind of a really intense tightness that she would describe as being, but very different than the other spot. So she hasn't really had any issues with this knee in the past. She was a patient of Bo's from a long time ago. She had had some low back stuff. I think she had knee pain on the other side, just over the years, but nothing quite like this. Nothing that really had to keep her out of playing tennis for that long. So that's kind of the main thing that I got out of like her mental state that day in the visit. She was just very bummed that she hasn't been able to work out, hasn't been able to play tennis. She really likes to go on walks with her friends, and she hasn't been able to do any of those. So she's pretty much done nothing for like 3 weeks. So I knew that was going to be like a big part of it. Then in addition, prior to seeing me, she had seen an orthopedist here in town. And with that doctor, she had gotten the swelling drained and had a corticosteroid injection, which she said that the draining was the most relieving thing. That felt really good. Obviously, the swelling came back, but the steroid shot was kind of hit or miss. She didn't feel much of a difference. And then he ordered an MRI, and she had the results to show me the first day, which I don't know, Corey, what do you think whenever somebody comes in and they already have images in hand, report for you? What goes through your mind with what you're going to do with that?
Well, I'm just like upfront and honest with the patient. I always say, like, I understand that you have imaging from previous care, previous assessment, but I would like to talk through what's been going on, do my own assessment without looking at it first, so that it doesn't stray me in any direction. I will absolutely take a look at it, maybe after treatment or our assessment and potential treatment today, and just see kind of what they said, or what I think from the images, and then we can include that in care. But for me to look at that, it's an image is just a snapshot in time, and you're looking at somebody in more of a dynamic way. So like, does it help us? Maybe in terms of like red flags, but for me, even if that is the case, hopefully my assessment will show that maybe treatment isn't the best thing today, and then we can move to the imaging sooner. So I'm always upfront with the patient. I'm like, I'll take a look at it eventually, but I want to do an assessment without that leading me in any direction first, because you're here for a reason, and it's because you haven't gotten help yet. And so I want to do the best that I can to make sure that I can help you the best without that.
Right. Absolutely. That's exactly kind of how I explained it to her, was that I'm definitely going to look at it. I don't think I looked at it till afterwards though. As far as the report and the imaging went, she brought a CD so we could look at it, but I was like, hey, it is a snapshot in time and we will look at it. I won't disregard it, but let's do our exam as well. So
Yeah.
after the visit, I looked at the report and looked at the image with Bo and Daniel, and it basically the gist of the MRI was that there were some normal degenerative changes around her knee. Or more specifically, like the things that were potentially concerning. There was some hyperostosis around the tibial plateau that was playing a role in what they called like a suspected contusion of one of the posterior horn, the left medial meniscus. So that was like something that wasn't necessarily called as being associated, but was like, yeah, I mean, with the bony change on the tibial plateau, that could have just been over time compressing on the meniscus. They also noted, obviously, the swelling in that suprapatellar pouch, and then suspected grade 2 strain of left popliteus, which I don't know. It didn't say that there was, and when we looked on the imaging, we didn't see anything either. But maybe just because of where she had said it, that was what they were thinking in the impression. But nothing that made, I guess, the ortho say, okay, hey, this doesn't need conservative treatment. Otherwise, he's a good friend of ours, so otherwise I don't think he would have sent her here. So anything on that tells you thus far, Corey, that you'd like to know more about, or I mean, how you would have been thinking when you read that?
No, not really, but can you just do like a quick summary, like age? She's female, obviously. She came in with left or right sided knee pain, all this stuff, just like summarize, and then we have a clean slate to talk about the rest.
Yep. 48-year-old female, active, plays tennis a lot each week. She has left sided knee pain that began with unknown origin, 2 pain locations, feels like it catches, and associated swelling. So
okay.
And like I said, biggest thing that she's worried about is not being able to like do the active things that she likes to do. So
we like patients like this, right?
Yeah, like she's gonna do what I ask her to do. And she was very, very compliant with what we were doing. So pertinent exam findings. So on top tier SFMA, she moves really well. The only things that I had thus far were multi-segmental rotation bilaterally, dysfunctional, non-painful, and then single leg stance on the left, dysfunctional, non-painful. So the same side as knee pain. And then range of motion. So obviously that left knee, limited flexion, extension, both for painful, passive and active, and then painful and passive tibial external rotation. So that kind of reproduced that posterior pain where she felt the hinging, and most of that, the hinging pain was on that external rotation and then also on knee flexion. The anterior pain was kind of more on the front whenever she was extending. And then whenever I would take her knee through terminal extension, her quads would contract to kind of like prevent me from getting there. And that's important because that was kind of a measure that I use pretty much every visit, that you'll see as we keep going. Relevant orthopedic tests. I guess I won't really include the negatives except for Thessaly's, which I thought was interesting that was negative. And we had the meniscus stuff show up on imaging, but that didn't cause her any pain. Posterior drawer recreated that posterolateral knee pain. And then Apley's, obviously, when I went into tibial external rotation. So kind of just the same thing as that range of motion test.
So quick question. When
Yeah.
you said that she has discomfort with flexion, extension, passive and active, but then Thessaly's was not painful. Are you were when she had discomfort, was it more end range flexion
Yeah.
that it was on?
Yeah. And I couldn't get to full end range of either, but like, so let's say when I'm taking her into flexion, I would say first visit, probably when I got her like a little past 90 degrees, she would feel that kind of hinge or the catch on the posterior part of her knee. And then I couldn't really push it farther than that. And the extension was kind of a similar thing where I'd push it a little bit and then she'd feel it kind of catch, and then she would contract her quads to keep me from going farther. And she would notably say, she would go, "I'm not trying to do that. Like, I'm trying to let you push my knee, but it just feels like it's gonna buckle." So so yeah. And then trigger points in lateral gastroc, popliteus, and vastus lateralis. So I don't even remember if I got that all on the same visit. That might have been like between the first two. Because I'll be honest, like, I'm 2 months out of school and I don't feel those very well. They were tender to her, and so I made a note of it. And so my main audits up until this point were the range of motion in her knee, because I mean, to really assess the knee further, I wanted to be able to actually get her to in range. And I couldn't do that without pain thus far. And mainly extension, because walking gait seemed to be the thing that was most obstructed for her. Like, in order to be able to do any of those things that she likes to do, she got to be able to extend her knee. And then the tender points or the trigger points in those different muscles around her knee. Those were kind of my two main audits. Any other thing that you probably would have included in your audit list, Corey?
Well, I didn't assess her, so maybe, I don't know. But when somebody comes in and they not only have discomfort, especially with movement, but they have swelling in a joint like the knee, which is the biggest joint in the body, right? Then I'm already kind of thinking that we, in some way, we need to treat the knee because it's swollen, right? Yeah. And you said that she had worse single leg stance on her left side, which makes sense, right? If there's swelling within a joint, we don't really have that, good afference or input from the knee to the brain to, be more aware of that limb. And so it's already throwing things off. And as you go through your assessment, you said there's discomfort with, a couple of things. So, Apley's and, full flexion, full extension, posterior drawer, those are all uncomfortable for her. But we have to remember the point of orthopedic exams are really, for the most part, with some exceptions, to check the integrity of the joint passive stability structures. And it sounds like they're intact, right? And so now you're already in a place where you can instill some confidence that she doesn't need surgery, even though an ortho sent her to the office, and she's probably expecting that. It's still nice to hear, just like from your perspective, where your head is at in terms of where treatment could go. Now, that being said, so swollen knee, painful knee, you're going to treat the knee in some way, but there's also other aspects of function that we can assess. And day one, like, sometimes you're probably not going to get to that because she's there for knee pain. It takes a while to work something like that up. But subsequent visits, I'm looking at the hip, I'm looking at the foot on that side and the other side, seeing if there's any other areas that we can focus on because the knee is so inflamed, right? So then that gives you areas that you can work on that that are improving, that may be indirect to the main complaint, which sets you up for more visits with the patient and time for them to heal, so that you can start seeing progress in the positive direction. But I'll let you continue with those things. Those are just thoughts that I had while you were telling me that.
Yeah. Yeah. So the interventions that we attempted first visit, it's quite a list. So with her low back history, I was like, okay, I'm gonna just rule out any potential lumbar referral. Used a lot of McKinsey method for that and didn't find anything that changed her knee, right?
Good for you. So like painful swollen knee, I might have to, like, good for you for being on top of that.
Well, I've seen it before. I haven't seen it where it was swollen like that, but I've seen knee pain that was because of back. So I was like, all right, we'll do that. Then I thought, all right, we'll go more through like cutaneous nerve entrapment on that area. And so I cupped around the posterior lateral part of the knee, with a little bit of dynamic movement that she would allow me to do, right? Passively. Minimal change there. So like, okay. At this point, I had spent a ton of time. I don't remember if I ran over. I probably did, but I wasn't busy at that point. So I was like, all right, well, we'll see what we can do. So then I dry needled those, I dry needled the popliteus and the lateral gastroc, which there was relief after doing that. So I was like, okay, we're getting somewhere. Wasn't really able to perform any extremity MDT due to the pain and not really being able to get to end range on that knee. And then to finish it after the needling, I was like, all right, we're gonna just put her into a hang stance, DNS hang stance, and just isometrically load it, see if it allows her to walk any different. I didn't expect really the swelling to change or anything, but so by the end of it, she was walking a little bit better. Slight pain improvement, no real functional change. That was kind of the gist of our first visit. And so I didn't really have much to send her home with other than the hang stance and like, hey, let's see how the needling felt after a few days, which was kind of what happened. So when she came back, she said, yeah, I felt better for about a day. And then it slowly started to come back. So I'm kind of back to where I was. This was probably like, I saw her Friday, then saw her Monday kind of thing. So then she's pretty much the same whenever I see her that day. Same range of motion, same pain, same swelling. At that point, yep.
Through your interviewing with her, were there any fluctuations in swelling, like time of day or after certain activities it was worse?
Yeah. I think at this point it had still all been the same. And she wasn't really doing any activity either at this point, so it was staying the same. The only thing that had ever changed it was when she got it drained.
Okay.
So yeah, it was still about the same. And then, but that day, I think maybe I had talked with Bo or Daniel about ways. No, it was Sloan. I saw her do this with somebody, and I was like, I can put a bolster behind her knee and try to take her through extension with that, just like a foam bolster behind it. And so she was able to do that with less discomfort in the office, and it improved knee extension a little bit. Like I could get her farther before she would contract her knee.
Okay.
So I was like, okay, I'm going to send you home with that. That was the main part of that visit. And I was hoping like, okay, this will maybe take down some of the swelling and allow her to at least get back to a normal walking gait. And so that's, doing more for us than against us. Because she's like, my hip's a little bit sore. Everything's just a little more sore now because she's walking funny. Right.
Right.
And, still frustrated that she's not able to, be active. So over the next 2 visits, various interventions, me just running around with my head cut off, spinning my wheels, just looking to get some kind of pain relief or swelling relief because, and I can hear Bo telling me like, hey, you need to treat function at the same time. Like you said, I wanted to get the swelling out. I wanted to get her knee feeling better. One so that she could have a little bit of light at the end of the tunnel, that this is actually going in a positive direction. Because she had planned on seeing, she had a follow-up scheduled with the ortho like a few weeks out. I think it was like 4 weeks from whenever he saw her, because he was like, hey, let's try this conservative route. And then if it's no better, then we'll check back in. So my goal was like, hey, let's make some change before you need to go back to the ortho. So I think some of the things that I had done over those next 2 visits were like, we tried some isometric split squat positions, reverse sliding lunges, because she had told me lunging is something that she really likes to do in the gym, but she also wasn't, for those 4 weeks up until that point, she wasn't putting any kind of split weight on that leg at all. And so we were able to, in office that day, do some lunging, like, controlled lunging and split squat. And she was like, that's the first time I've actually put weight on that knee in 4 weeks. So there wasn't much change in pain, but I was like, okay, that might have been a small win, because up until that point, she hadn't tried to even trust that her leg could do that.
Right. It didn't make it worse. I think that's valuable.
Yeah. So she felt, and I do, maybe to her detriment sometimes, I think she wanted me to feel like I was doing a good job, and she'd be like, that might be a little bit better. And in my head, I'm like, that is the exact same. That looks no different.
Yeah.
But I mean, she was sweet. So at this point, I think was when I had dry needled her vastus lateralis. We did some foam rolling over that side. And that had created a bit of a change in the range of motion again to let me get to farther knee extension. But she still had that protective contraction at the end. Well, not even true end range. So at that point, I was like, all right, I'll send you home with the foam rolling. You can still take tension down in the muscle. I have a feeling it's not fixing anything, because it's kind of the same story as the popliteus and the lateral gastroc, where we took tension down out of those muscles, but then it just came right back. And so we looked a little bit at foot function. She had a little bit of a bunion formation on both sides. And the knee sits between your ankle and your hip, and her hip moves pretty good. So I was like, let's do something at the ankle or the foot. So that yielded little result. And so any other questions you got to this point, Corey? Because we got the next visit.
Just a comment, and this is just based off of being in a PT office for a number of years. Very above average PTs, maybe not, accelerated from like a rehab to performance like perspective, but way better than just like a PT mill. For most scenarios, but more specifically in this case, where there is a swollen left knee, and you're fighting with yourself, like, how do I improve function? How do I treat function at the same time as like getting the knee to calm down a little bit? You have to think about, and you probably did, like, what is potentially causing the knee to swell up if imaging is clear and your orthopedic exam and red flags are clear, right? It just like makes us ponder, like, what the heck is going on here that's making this knee swell up? And so I had a patient in student clinic, actually at Logan, that had idiopathic knee swelling, and maybe not as consistent or constant as your patient here, but it's a pain to treat when there's no like onset of symptoms and swelling, and it's not like red and a case for you to like refer and get more tests done. She already kind of do that part anyway. It's like, why the heck is this happening? So from like a traditional physical therapy perspective, they would do manual therapy like you did, like you're treating muscles that are holding tension. We know that's happening because the brain doesn't sense safety in the knee, so we hold tension to protect it. So that's clearing up discomfort in the short term, but not fixing the issue, which like I was saying, so from a traditional physical therapy perspective, and maybe I'm bastardizing it, but their approach might actually include this type of progression. So going from like manual therapy, open up range of motion, maybe clear some discomfort, maybe flush out some swelling, to open chain exercises, which you're actually trying to do with MDT. But they would probably do something like quad sets with a lift, so contracting the quad and lifting the leg straight up. But something that's low level in the open chain, so that the exercises are a little bit more constrained for safety. So you're sending her home with, you want her to be able to walk well. Maybe you did some hanging stance. You're doing lunges and stuff in the gym. From a functional perspective, that makes sense. Maybe some like, foot yoga, whatever. But the knee is inflamed for some reason. And so it might not, like for me being on the outside, I would have done the same thing. I promise you that. I would have done some loading and stuff like that. But from the outside now hearing it, I'm thinking, okay, maybe the knee isn't ready for that. Like if the passive structures of the knee aren't damaged to the point where it needs surgery, and even if they were, they may or may not need it, then maybe I can dial it back a little bit and work on something that's like super low level and just see if we can, get the knee to kind of let go of some inflammation or like kind of flush it out, or set her up for that a little bit better, if that makes sense. So like modifying exercises, maybe not doing something in the closed chain right now because, something could be off where the knee has to make up for movement, which is exactly what you're saying. So in the short term, just based off of my experience being in that office, maybe that's for me at this point a route that I would have tried to dabble with, knowing the scenario that you're in already.
Mhm. Yeah.
That was the comment.
Yeah. Well, thanks for bringing that up, because I too was asking myself why would her knee be swollen if I don't think any of these structures are, damaged to the point that we would see it on imaging. And I realized that, danger inside me could say, hey, I'm going to put the swelling here, put these protective muscular tension around this joint because I sense that there's something not stable or there's some kind of threat. But I hadn't, like you said, I hadn't seen anybody. You had at least seen somebody, I guess, in clinic, but I hadn't seen anybody that was just idiopathic swelling for no reason. Since then, I have seen one person, but that person also has other underlying conditions, right? Like he's got hypertension, he's not a very active person. And so that and he literally locked down his foot, like hasn't moved it for 6 months. So that makes sense to me, as opposed to this lady who's, the epitome of health at almost 50 years old. So,
right. So it's like, it's the patient we want, but the hardest to work with.
Yeah.
They've already pretty much done everything on their own.
Right. Yeah, absolutely. So, okay. So at this point we're at visit 5. And she had gone to her follow up with the ortho. He suggested next step would probably be scoping the knee to get a better assessment of the meniscus and deciding if they need to clean anything out while they're in there. I'm tired of spinning my wheels, feeling like I'm doing her a disservice a little bit at this point by not having it figured out, which Bo can probably attest seems to be my demise a lot.
It's okay. We don't have to know everything, right?
So I asked him for some help. I was like, all right, man, I don't know what I'm not doing here, what I'm missing on assessment. Like, what do you think that I should look at next? So he sits in while I'm doing my exam, like kind of doing a re-exam a little bit. And then he also does one as well to kind of look at it himself to get his feel on it. And after we talked a little bit at that point, he was like, you know what? I think it could be a little bit more of the PCL than meniscus. Because a piece of the history that had not been revealed yet, because she hadn't done this yet, but prior to this visit, she had gone to a formal event, worn heels. She was like, when I wore the heels, my knee felt totally better, like not totally better, but it was a lot better. And so he was like, if, she's wearing that high heel, it's putting her knee into a position where it doesn't have to get to that in-range extension. And so it's not compromising the PCL, or her body doesn't sense that same threat as it would be if she was just walking normal in regular footwear. All of the areas of muscular tension are still there as a result, trying to protect that knee to keep her out of terminal knee extension. Whether this PCL was a prior injury kind of thing, or for some reason got irritated, wasn't bad enough to show up on imaging. So at that point, the game plan, which kind of was there from the beginning, I just didn't pinpoint it, was to restore the terminal knee extension. But now with the idea of, okay, and then we can fully assess the PCL's integrity once we get it to terminal knee extension. So something that I didn't know that he pointed out to me was like, whenever you've got something going on like this that's been there for a while, I would actually have them passively at home hang out in extension for like 20 minutes or so, just to let their leg rest on an ottoman or something, sitting at the couch or whatever, and see if that over time can allow her to get there further instead of just trying to push it, right? Because she has that protective mechanism every time that's going to keep her from doing it, which made sense to me. So that's all we sent her home with after that first visit. And in visit that day, he had done some more some hang stance, right? Like, and while in hang stance, trying to get her to extend her knee by putting axial load through her hip. So a similar thing to what we've been doing, but just trying to, again, see if he could get anything outside of extension, and it was minimally effective. So that's when he was like, all right, I'm doing this passive thing at home. Okay. Minimal change the next visit. Next 2 visits, still minimal change in extension, but now we're doing the first time she had gone back to the gym. So I think this is, I've got visit 7, visit 8. So probably like 3 weeks or more since I started seeing her, 6, 7 weeks since it started hurting, maybe 8 weeks that she hasn't been to the gym. She was like, I'm getting stir crazy. I need to go do something. So she said, I did some elliptical, I did some kettlebell swings. And she goes, I feel like I'm doing better. That's kind of her every time she comes in. But really she goes, I think that it did a lot more for my mind that I could go do my normal thing and go to the gym, even if it wasn't what I normally do. So like, okay, all right. So we made a little bit of progress in regards to doing something that's more normal for her. So I think you looked like you had something that you were wanting to say there. No?
Oh, I mean, it's a win, right? And that's something I say this just like as an aside, for when I'm talking to, colleagues and students. It's like anytime you do get a win, it's always big, so always celebrate it. You know what I mean? Like it seems so simple that, maybe the knee hasn't improved any after 6 or 7 visits, but she's doing something that she previously thought she couldn't do, and it's not making things worse. So like I'm high-fiving her, like celebrating the heck out of that,
Yeah.
because that's important. Like you're trying to create this therapeutic alliance with all the patients that you see. You're not going to help everybody, and especially not going to help everybody like quickly. Like we think we can get people out of pain and like to full function within a couple of visits. Like that's not reality. And so like when something like this happens, I'm celebrating it, and that's somebody that's going to continue to be with me, even though I like for whatever reason I can't help them. Like I saw a patient for 2 years straight, didn't get any better. She like went up and down through the course of the year. And she just like, she would always come back every single week. Didn't matter. You know what I mean? Like that's still valuable, because that person is, from like a sales perspective, I think of this, but like also just being really passionate about what we do. If that person is seeing you on a consistent basis, they are better off with you in the office than seeing somebody else, because you're actually like actively trying to help her. Right. And just the fact that she knows that is helping, even though her knee isn't improving yet. Right. So I think we downplay it sometimes, like, oh yeah, she's just like trying to be nice, but like you're trying to help her, and nobody else would put this much time and effort into it, like you can, or like you are. So it's important to celebrate that.
That's a good point. Looking back on it now, I'll explain to patients that typically like improvement would either be you can do the same amount of activity with less pain, or you're doing more with the same amount of pain. And I've literally disregarded the fact that she's doing more and she's got the same amount of pain. It's just she's now back to doing some things she wasn't doing.
Yeah.
So looking back on it now, this is kind of a bit of a pivotal moment in her care plan. So this is visit 7 to 8. And at this point, so some of the things that I literally forgot to do in the previous visit, after we figured the whole thing out with the high heels, we were like, hey, why don't we do something heel elevated to get to do right, to again mobilize her knee, but also put her in a position that she already told us feels better. So that next visit, I was like, all right, we're going to do some heel elevated split squat. We did kettlebell deadlift, same thing, just literally played around with on a wedge a bunch, which I know you're a fan of.
You're getting me excited now.
Yeah. So, and things are still getting better. She like, I would say the improvements on the table thus far is I can get her to farther extension. She still contracts on me. There's no swelling has gone down. There's pretty much very minimal swelling now in the knee. She still gets about the same amount of extension passively, contracts, flexion is better, still feels that hinge, maybe like 120 degrees or so. And so I'm like, all right, I do still think that you should go see the ortho. Because this was kind of a case where the management of it all was really important between different practitioners. So she had seen this ortho, he was out of network for her. She was going to go see somebody else. And so she had a consultation with him scheduled for like a few weeks out. So we were kind of working towards this, and the goal, then the thought was like, hey, if we don't get any better, you're going to see him for the consultation of we need an arthroscopic procedure. So up until that point, that was what we were going after. She comes back. We've got 2 weeks till she has that new appointment with the new ortho. She's got improvement in pain, but I'm watching her walk into the office, and I was like, oh, she's walking kind of normal. Not, normal-ish, better than she had been. She tells me, she's like, I went to the gym 4 times last week, and it helped me so much just to go do that part of my routine that I had been missing out on. She goes, and listen to this. I contemplated trying to play tennis. She said, I didn't go do it, but I thought about doing it. And she said, last week, I wouldn't even thought about that. So I was like, okay, all right. I mean, I feel like I'm not having to point out these things to her that are progress. She's figuring it out on her own, which was pretty cool. Probably because she's just looking for any kind of progress at this point. And so I asked her, I was like, all right, so when you're doing things in the gym, what did you what were things that you still had trouble with that you were doing? She said, well, when I'm squatting, whether I've got weight or not, I feel like I shift away from my left side. Like I don't want to load that side, which makes sense because she doesn't want to go through flexion. And so I watch her do it, and she definitely she gets to that point where it feels like she's going to hinge, and then she shifts over to the right. So I can't remember quite what we did that day in the office, but I did something to see if it would change that shifting of her squat, and didn't really. This might have been right around the time that we got back from the symposium. And so I pulled out my little 2-point discrimination on her, and it was different on the left knee versus the right knee. Not crazy different. Like I think the knee is supposed to be like 40 something ish, 40 millimeters. And she could pick up to 60 on the left knee, and that was about it. So whereas the right, she could get like 30. So I remember what it was. We had some of the Rock Tape cups with vibration on them. So I stuck those on there, had her move around, did the squat again, no change. But just was like, hey, we just learned that, so we'll give it a shot.
Right.
Yeah. So visit 10, she comes in. I'm watching her walk. She's walking normal. I was like, okay, all right. So we check things out, and honestly, I was expecting on the terminal knee extension for it to be totally normal. She got much farther. She still had that protective contraction at the end. But I would say she's resting in closer to normal end range of extension. There's no swelling. Flexion is about the same. I would say flexion hasn't changed. She still hits that hinge. She still shifts in her squat. But at this point, she's like, I went for 2 walks last week, and I had pain in my knee the first half of both walks, but then it got better. as like about halfway through, which was odd because one was 30 minutes and one was 60 minutes. So 15 minutes in, started feeling better. 30 minutes in, the other one started feeling better. But she was like, I mean, it was really helpful that I could still get out there and go walk with some of my friends. So those were kind of our latest updates on that. She then was supposed to have her appointment with the ortho like 2 days later. And I was like, yes, let's still go do that. I mean, you're still having we haven't made much more improvement in the flexion. The extension, while we can get you farther, you still don't want to let me get there. So she's going to see him. She was going this week. And a piece of this also that I'll mention for the whole case management thing was she was like, hey, can you send him a note or a general synopsis of what we've been working on, just so that he has an idea when I go see him and feels like he's kind of up to speed, because I don't know that I could explain it all. I was like, yeah, that's fine with me. So he's a friend of Bo's, so we were chatting and he goes, hey, he told me to send him a text whenever I have something that he wants to look at, because he goes, if you send a note, I'm probably not going to read it. I was like, okay. So I'm typing up what all's going on. And I said, all right, Bo, how does this look? And he goes, no. Not I need 2 sentences. I've got a whole 3-paragraph thing of what's going on. And he goes, the main thing is you have to tell him what you think is going on. And you got to pick one thing, right? Don't say it could be PCL, it could be lateral meniscus. Because they just want to know what the thing is you think so that they can assess it and look at it, because it's not a knock against orthos, but they're not the same caliber when it comes to diagnostics that we're going to be in the exam room, right? So it came down to it that I ended up just not putting all that together, putting a text together and just send him the note anyway. Whether he reads it or not, that was more of a, if she asks, hey, I sent him the note.
It's
Because
always wrecking to send another provider. And
yeah, I feel like I write pretty decent notes. I'm not busy enough to the point where I literally don't have time to write a super thorough, in-depth note while I'm in there. I might have to do it afterwards if I've got a lot of people and then I have a new one in the middle. But for the most part, I mean, I'll stay after work because I'm not going home to do a note. And if I don't do it before I leave, it could slip through the cracks. And so it's going to be done before I leave. But that being said, yeah, still sending a note, no matter how thorough it is, you're like, he didn't feel it. He didn't see it. He doesn't know her. So there's always that kind of, I'm a little worried that the message isn't going to get relayed through the note. But so we will follow up whenever after she has that. Well, she had that appointment and then she's going to schedule with me, I'm guessing, I think next week. So
question for you. Why do you think now, 10 visits in, which how much time has allotted from visit 1?
December 30th was visit 1.
Okay.
So it's February 13th was the last visit.
Okay.
Month and a half.
Yeah, almost 2 months. So over the last couple months working with her, why do you think she is now starting to see a little bit of improvement in her knee? And honestly, your audits are also changing, maybe not drastically, but there are positive change to your audits too. Why do you think that change has taken place?
Question.
Yeah.
I think the biggest piece would be she started to trust her knee a little more. So she's allowing her knee to get into further extension, because that's in my opinion, the main reason why it's not going into full extension is because her body senses a threat, so she's not allowing it to get there. And slowly she's introduced things that have been to de-escalate her threat. She's gone on walks, she's gone back to the gym. And we're seeing that now in how she's walking, how far we can get her knee into extension before she does hit that protection. And yeah, I guess those would be the main things.
So yeah, good. There you hit one part. I'll kind of summarize why I'm asking, but what do we know about like, let's just think about like an acute injury, like an ankle sprain. Not like so severe that, you have a Weber's fracture or something like that, or Jones fracture, but you sprain your ankle, like what is traditionally what we would do versus what we know to be really helpful now in terms
Yeah.
of tissue.
Yeah. So traditionally we do some rice and we just keep it rested, not really move it a lot, elevate it. And then now we're getting that ankle moving as soon as possible to reduce swelling, promote positive movement experience. So
Right. Yeah. So now, like, she was pretty stagnant until, your sixth, seventh, eighth, ninth, 10th treatment. She started moving more. And now, she's building confidence. Yes, it's really important, but she's walking more. She's getting in the gym and doing somewhat of a normal routine. She's not doing tennis yet, which, for her, that's probably the activity that she's the most, ballistic, or would change the direction and things that maybe her knee is not ready for. Because I guarantee, and this is a place, this is why I always say that we should know the strength and conditioning side pretty well as providers, even if we're not going to do a whole lot of it. If her training doesn't reflect what she needs to be able to do out on the tennis court, even if it's recreational, then she's not setting herself up for success. And that's where we can kind of implement ourselves from that, bridging the gap from, the knee swelling going away, building the foundational stability, and then keeping her around to make sure that she's doing things training wise in the gym to prepare her for the activity that she actually wants to do, which is tennis, right? And so now she's not doing the activity that probably caused the issue in the first place, but she's still being active in other ways. So now the knee is recovering a little bit. She's moving more, some progress along the way. Yeah, maybe there is some PCL, maybe the integrity of the PCL is inhibited in some way. But you did the right thing in terms of like making sure that she did follow up with the ortho so that he can look at it more thoroughly. There's nothing wrong with that collaboration, especially if it's somebody that's well established in terms of relationships with the farm. It just makes sense to use him when you need him. So now, to kind of summarize, so there's been a couple months that's time to heal. And also, especially over the last, few weeks, she's been moving more. So now things are starting to come along. Audits are changing. She's improving range of motion. That doesn't mean that treatment is over by any means. Like you have goals for her, and also she wants to get back to playing tennis. So you need to get that thing back to, full extension within, her limitations, which is what you're trying to do. Sometimes it takes longer than, 10 visits. But now that, she's building a little bit of confidence, things are healing, she's avoiding the activity that likely caused the issue in the first place, like things are starting to come around. That is by no means like a failure in treatment. Like that's like, I always try to, you can't, this is why the first year of practice you learn the most. It's like theoretically you have the things that you know that will likely help, that it's not black and white. And now you're hitting the reality of it. Like sometimes it takes 10 plus visits for things to come around or you to actually figure it out, which is fine. That's why with our conversation earlier about celebrating little wins and making sure that she knows that you're actually trying to help her is important, because eventually you will figure it out, whether that's with you or another provider, and you'll get them to that place. But then they're always going to come back to you and send people to you. So like it's you get the benefit of, both helping her eventually, and, the business wise, you see her for more visits, which sounds cringy, but you need to run a business, and she refers people to you. So like all in all, this experience, in my opinion, is way more valuable, and you should pat yourself on the back more for something like this versus something you got better within 6 visits or less. Like learning wise and like everything that came out of it, you reflecting on the whole experience is extremely valuable. And you learn way more with this case, even though she's still not 100% yet.
Yeah.
All right. So anyway, I went on a little tangent, but there was time to heal, and she was moving more in ways that weren't provoking her knee. And now things are starting to happen. And I can dive into the biomechanics of the knee and why, potentially why wearing heels or doing things heel elevated has been helpful. But like we could talk about the nuances, but it doesn't matter for the patient. And what matters is she's building confidence with movement, and that's coaching perspective way more important than the nuances of biomechanics. But yes.
Well, and I guess the next piece of it that hasn't been answered for me is like why it happened in the first place. If tennis was the true provocative movement, and it didn't hurt her while she was playing, right? How do I know that, she gets back to full knee extension, no swelling, no pain, no restriction in range of motion. She goes back to play tennis. How am I going to know that? Oh yeah, you're good to go play tennis when I restored knee extension, but I guess I don't know if it wasn't there before she was having this incident. That's the only thing I don't know about functionally.
Yeah. I don't think it matters. Like this is when Bo talks about like not creating a narrative, this is what it means. Well, twofold, like from what you think personally about what's going on and then what we actually say to the patient, like is probably more important when we're treating humans. Like it doesn't matter what came first or like, what actually caused the issue. What matters is that now you have a meaningful movement that she wants to get back to, and you can ask her questions or do some research on the things that are requisite or prerequisites to being able to do that activity in a way that's mitigating risk, not preventing it. Right? We can only decrease risk based off of like how we implement treatment. We can never take it away. And so, we know functionally that her knee needs to get full extension, and we would like more flexion, but she doesn't need more at this point because she's not full squatting while playing tennis probably. So now look at the demands of the sport, and then your treatment should progress to whatever those demands are. And if she can get through a full treatment and the next couple of days things don't flare up, then she's probably ready to get back to it. And maybe even sooner. It just depends on how conservative you want to play it and where she is in terms of like how anxious she is to get back. Or like she's 48 years old, so like you could tell her, let's just wait until we get up to full speed, change of direction laterally, forward and back, etc. Before we get back to it, versus like working with an athlete that's competing. That's two completely different scenarios. You're probably working with the better scenario that you can say, hey, let's just wait and then see what it looks like when you're increasing the rate of force on movements that you're working on in the clinic and see how it responds.
Yeah. Fair enough. Keep those in mind.
That's fun. That's like the stuff I really enjoy, like getting back to the performance things, because it helps. Like they're going to see a lot of progress. You're going to pick out a lot of things that they can work on and implement in their own workouts. And obviously she's motivated. So it just gets really fun to like get somebody off the table and work on those things.
Mm-hmm. Yeah. Perfect. That's all I've got for the case. Any closing comments?
That was really good. I think what's something that myself and whoever's going to moderate case studies later on, I think doing like a summary on the principles that we talk about within, our fundamentals courses and just like how we communicate within the residency, that should be non-negotiables in terms of treatment or, being a part of this organization, and highlighting what you're doing really well. You assessed an individual well, functionally and locally. You came up with audits that were painful audits and functional audits, and some were more meaningful to you than others, so you stuck to them. You implemented treatment on a consistent basis, which I think is not talked about enough. Like what does visit 2, 3, 4, 5, 6 and plus look like? You stuck with a treatment had a similar intention and maybe changed up your treatment based off that intention. I think that's really good. And then you're collaborating with other, professionals to see or make sure that, things are stabilizing appropriately, whatever. You went through that whole progression though. Like you didn't skip steps. You rolled out the lumbar spine, even though the knee is swollen. Like you did really well in terms of, sticking to the principles of what we talk about, which is exactly like, that's the best that we can give, right? We don't have the luxury of skipping more steps that Bo might have, but he has the clinical reasoning and the ability to make changes based off his assessment because he's seen more of it. So just zooming out a little bit and looking at your whole process, like you did really well at sticking to those principles that we talk about and implementing them. So I hope that's something that, students or docs that are listening to this are picking up on and listening to as you talk through the case study. It was really good.
Awesome. Thanks, Fox. Appreciate it. That I like that. That'll be a new idea for the end of the case studies. Have this synopsis, right? Because I really enjoy when I have you on as a moderator, and we're going to try to have other people too, like probably have Kyle Utley kind of a similar position as you as far as years out of school and what he's doing. We might have Bo or somebody else here on there as well. So yeah, I'll make sure.
I think I'm the nicest moderator out of all of them. We'll see.
Well, you're not Canadian, so that's already point one for you.
No comment.
All right, pal.
Yeah.
Oh man, well, good deal. Well, guys, we hope you enjoyed this little case study. And if you like this kind of format, like I said, we're doing a little bit different this season, kind of having 3 different episode formats. If you're enjoying it, let us know somehow. Send the R2P Instagram a DM. You can send one to me, to Sean, to Connor, whoever. And we really appreciate if you would share this with your friends, your colleagues, your classmates, on all your platforms, however you choose to do that. And yeah, give us feedback on how we can do this better, what cases you want to hear, who you want to hear from, topics you want to hear us discuss. So, all right. Well, Corey, appreciate you hopping on, man. And we will see you in the next one.
Yeah, thanks for having me. It's always a pleasure getting on with you guys.
Thanks, sir.